The whole of India will now tell, I think. Okay. I welcome everyone for this session on stimulation protocols for endometrial preparation in FET. So as more and more cycles are going in for frozen embryo transfers to prevent OHSS or for various other reasons, I think preparation of the endometrium is a very integral part of a successful IVF program. And today we will get to learn about various methods. So over to you, sir.
Okay, so I will just start sharing the screen. Shilpa madam and Dipesh bhai can stay unmuted so that I can see if the screen sharing is going good. Yeah, clean, na?
Yes, sir.
Okay, so you know, whenever we are trying to talk of this, right? Whenever we are trying to talk of endometrial preparation for FET, we all know that there are now multiple protocols which are available. All right. Now, I will just try to discuss the top 4 protocols which I do. Okay. And I'll tell what is the commonest which I do. So first I will write down the 2 least commonest ones. Okay. Which I do. Okay. Anybody else can do whatever they want to do. I am only going to be discussing what I am doing. Okay. So the first protocol is GnRH agonist HRT, hormone replacement therapy. Okay. The second protocol is just HRT, hormone replacements. Third protocol is modified natural cycle stimulation. And the fourth one is true natural cycle stimulation. Okay. Now, what we need to understand whenever we are trying to prepare the endometrium for FET is that, see, we always try to correlate this, okay, that the endometrium, after getting naturally stimulated from the ovary, okay, the endometrium starts receiving the stimulation from the ovary, not from the day 2 or day 3 of the menstrual cycle. It's actually approximately day 4, day 5, once a dominant follicle gets selected. Okay, and once this dominant follicle starts, once this lead follicle starts becoming the dominant follicle, somewhere here it starts secreting estrogen. At this stage, there is an E2 peak, which is sustained. Okay. So as a result of which, what normally happens is, let's say this is day 2, day 3, this is around day 5, day 6, and this comes to approximately day 10 and day 11. So normally, even in a natural cycle, a completely natural cycle, God has gifted estrogen exposure to the endometrium for approximately 8 to 10 days. Okay. Just remember this important word. As a result of which, even if you were to give HRT, even if you give GnRH agonist HRT, and if you were to put estradiol exposure for less than 7 days, you may get a very good triple line endometrium, but you are exposing the patient to a very high risk of miscarriage. And you are also exposing the patient to a high risk of biochemical pregnancies. Okay. So just remember one important thing. Whenever you are doing HRT protocols of any form, minimum estradiol exposure should be at least more than 8 days. Now, how you do it more than 8 days is your lookout. The maximum which one can try to stretch it on is up to 28 days max. Okay. Beyond 28 days, what is going to happen is, due to prolonged estradiol, the estrogen receptors will go down and the endometrium would atrophy. Okay. But we'll come to that a little later. Okay. So just remember this important thing. In fact, once the follicle becomes 15 millimeter and goes from 15 millimeter to approximately 18 to 19 millimeter, from this 4 millimeter, okay, that's when the endometrium also grows rapidly. Okay, because this is the time when estradiol is at its peak. The homework is already done by this stage, and then the final shooting, the final development of excellent quality vasculature and everything is done usually once the follicle is around 18 to 19 millimeters, as a result of which, at the day of close to the trigger, we want to also assess the endometrial Doppler. Okay. And usually at around this time, the endometrial Doppler will show reaching almost up to the zone 4. Okay. And that is something which you need to keep in mind as a part of your folliculometry and correlation to the endometrium. Usually, when this happens in a natural cycle, endometrial peak is between 200 to 300, as a result of which approximately this much serum level of estradiol for around 2 days is sufficient enough to cause a very good endometrium. This exposure of endometrium is important because this endometrial exposure allows to develop progesterone receptors inside, and these progesterone receptors also allow for secretory changes, because without these progesterone receptors and secretory changes developing, there is going to be no implantation. Okay. Now, whenever we talk something about the secretory changes, I just want to mention one very important thing. I know a lot of people would always talk about matching the window of implantation. All right. So just want to give you one important theory about the window of implantation. Probably you have heard this before because all of you are very well read. Probably you have not heard this before. Okay. But just remember one thing. Okay. A good euploid embryo, okay, will itself cause crosstalk with endometrium. Okay. So as a result of which, it is extremely important that when you are doing IVF, you try to focus on getting a good euploid embryo. And the basis of getting a good euploid embryo is a good stimulation. Rather, I would not use the word good here. It is an excellent stimulation. You can supplement good euploid embryo confirmation by doing PGTA or by doing time-lapse imaging and going by morphological grading. Obviously, PGTA is way more superior. Time-lapse is a secondary marker. All right. So just remember this important line that a good euploid embryo will initiate crosstalk with the endometrium. Normally, this blastocyst embryo, okay, is going to be present in the endometrial cavity for approximately 48 hours before it undergoes the actual implantation. And it is this 48 hours that it is spending for doing this crosstalk with the endometrium. So God has given sufficient amount of time to the blastocyst embryo to go to this endometrium, which is present here inside, and have some communication with that. Okay. If the embryo is not a very euploid embryo, that is the biggest fallacy of PGTA. PGTA is a point of time analysis. So it can tell you that the embryo is a mosaic embryo, but the embryo develops the capacity of doing something called as autocorrection. And as a result of this, you will have mosaic embryos also allowing for an excellent implantation because they have autocorrected and then they have done a good crosstalk with the endometrium, which has resulted in an excellent implantation. The reason why I explained this entire theory to you in so much detail is because whenever we are talking of implantation, we are always worried about something called as window of implantation. To be very honest with you, none of us are aware what exactly is window of implantation. But what we do know is there is upregulation of certain genes and then there is downregulation of certain genes. Okay. And these genes can be upregulated and downregulated differentially. Okay. So for example, an Indian lady, okay, will have different upregulation as compared to an Arabic lady, as compared to a European lady, as compared to a Chinese lady. Okay. So kindly, you may rely on endometrial receptivity array, but you don't have to rely only on endometrial receptivity array for windows of implantation, because otherwise God has gifted around a 48-hour crosstalk time, as the result of which when you do something called as a true natural stimulation or a modified natural stimulation, that is when you are giving that particular endometrium the maximum window of implantation. So it is these two protocols which provide for max window of implantations, and they allow the embryo and endometrium to speak to each other the best. Okay. These two protocols will allow for a limited window of implantation. Okay. As a result of this, whenever you are doing exclusively HRT protocols, though I know there is not a great difference between day 2, day 3 transfers versus day 5, day 6 transfers, it is preferable that you do a day 5, day 6 transfers on HRT protocols. Here, what will happen is modified natural cycles is that irrespective of the day, you can do day 2, day 3, day 4, day 5, day 6, whatever you do. Okay, as long as the embryo is a euploid embryo, you are going to get enough and more time, and the implantation rates would be higher. Okay. Now I know there will be questions because implantation rates may not be higher. The world wants to move towards something called a single embryo transfers, and the world really wants to reduce pregnancy related complications. So we know one thing for sure. Unfortunately, in an HRT, the only products which we currently have available with us are estradiol, and then we have progesterone. Okay. We are not able to give any other product. So we may have add-ons, right? Some of us like to give add-ons like ecosprin. Some of them would give low molecular weight heparin. Some would give arginitric sachet. Okay. It depends on how much commercialization you follow, but all these things can be given. Now, what happens typically in modified natural cycles and true natural cycles is that apart from giving estradiol, which nature is giving, apart from giving progesterone, which nature is any which way is giving, nature also provides relaxin, nature also provides vascular endothelial growth factor, nature also provides for proteases, matrix metalloproteases, to be very true. I mean, very honest with you. It also provides a lot of activins. Okay. So what typically happens is these guys are also responsible for an excellent implantation. Okay. As a result of which your success rates with SET and your pregnancy induced complications will be much lower when you do a modified natural cycle or a true natural cycle. All right. With this much data into our heads, let us go one by one, okay, quickly into what is the standardization which we can achieve when we are doing a protocol. We can simply copy paste this protocol, and if we are able to copy paste the protocols, it will make our life very, very easy. And ultimately, these master classes are into simplifying the life for each and every consultant. All right. So whenever we are looking at these FET based protocols, okay, one thing is very, very important, and I think this is a very practical take home point for people. I really don't like to give this GnRH agonist based HRT. Okay, because this GnRH based agonist itself, no, it induces some amount of luteolysis. Okay, I don't really like it. In fact, whenever you are wanting to do FET, after your index cycle is complete, you should start with the FET immediately in the next cycle. Don't take that break. Your results will be higher. The reason your results will be higher is because that ovary would have developed some corpus luteum. Okay. And due to the development of this corpus luteum, the guys which we spoke about, no, there will be some concentration of VEGF, there will be some concentration of relaxin, which is present in the endometrium in your FET cycle, which will enhance your outcomes. If you have not tried it, try it. I have done a lot of these. In fact, I have only been doing it that way. I realized it very late that, oh, it was due to this. Okay, so I don't really like to give the GnRH agonist only because it causes luteolysis and then it reduces the values of VEGF and relaxin. Okay. So I will tell you what we normally do in an HRT protocol. If I just go from day 1, day 2, day 3, day 4, day 5, day 6, day 7, day 8, day 9, okay, I'll just draw it in that manner so that people can understand it very, very easily. Okay, because I'm going to explain you the ultrasounds predominantly. Okay, so what is going to happen is this is the protocol which we follow. So what we use in our practice is we use estradiol hemihydrate. Okay, and when we use estradiol hemihydrate, we normally give this estradiol hemihydrate as 4 milligrams. So that is 101 for the first 6 days. Okay, so from here on to here, it is going to be 4 milligrams, and then it becomes for the next 3 days. Okay, so these day number 7, day number 8, and day number 9. Okay, so here it is 4 milligrams, and here it becomes 6 milligrams. So one thing we have achieved approximately 9 days of estradiol exposure. Okay. After this, on the 10th day, the patient normally comes for an ultrasound. Okay. Obviously, the ultrasound is done also here on the first day, and we try to rule out any follicles. Okay. Or we try to rule out any cyst, and of course, the ET has to be thin. So the normal target for a thin ET is less than 4 millimeters. Okay. No triple lines. So normally, we would not do any estradiol progesterone here. We are not going to be doing E2 and progesterone values here. We normally would do an estradiol value here and the progesterone value here. Endometrial thickness, we try to keep more than 7 millimeters. Okay. Appearance, as we all know, triple line, and vascularity at least to be more than zone 3. Okay. On Doppler. So whenever estradiol and progesterone reports come, we are very happy if the value of estradiol is more than 300, and we are very happy if the value of progesterone is less than 1.2. I know the standard is 1.5, but this is what we have at our place. Now, this is the day. Okay, on the 10th day, once we decide, we have started progesterone. So day 10, 11, 12, 13, 14, 15. Okay, so when you give progesterone, I will mark it separately so that everyone can understand it beautifully. Okay, here you have given progesterone. Okay, here you have given progesterone, here progesterone, here progesterone, here and here. So this is your first day of progesterone. This is your second day of progesterone. This is your third. This is your fourth. This is your fifth. And this is your sixth day of progesterone. So your blastocyst transfer, okay, embryo transfer should occur on the 6th day of progesterone. And what is the progesterone which we give in our practice? So we are giving progesterone gel. Okay. So I normally give gel from a company called Progevian. That is from something called as Nivian Pharma. And I give it twice in a day, mandatory. Okay. And along with that, we also give Dufaston. We always like to give 2 methods of progesterone, and we give Dufaston 3 times in a day. Now, this exposure is enough along with your estradiol hemihydrate, which is continuing for 3 times a day. Okay. At the day of the embryo transfer, provided these and these criteria are satisfied, you will start with the progesterone, and the blastocysts would get transferred on the 6th day. We normally don't end up calculating at how many hours did we froze the embryo. Okay, so let's assume some embryo we freeze at 118 hours, some will be at 108 hours, and some will be at 122 hours. So let's assume I am to do, these are the 2 embryos which have been formed for the patient. Both are blastocysts. One is at 108 and one is at 122. Okay, I will still do the embryo transfer for both of them on the same time. Okay, I will do both the embryos on the same time. The important thing is do it on the 6th day of progesterone. Okay, once you do it on the 6th day of progesterone in an HRT protocol, the window of implantation is usually going to be 8 to 12 hours, and it will match off very, very nice. Okay, this is the standard HRT protocol which we follow. As I said, I don't use the GnRH agonist at all. Okay, and this is the absolute standard, the absolute carbon copy of the protocol which I have at my hospital, which I have declared here. All right. Sometimes in my practice, we are also going to be adding. Okay, sometimes in my practice, we are also going to be adding ecosprin to all of these patients, 75. Okay, we do not give low molecular weight heparin as standard. Okay, I know it is questionable. I don't really find any great benefit in giving low molecular weight protocol. I mean, low molecular weight heparin in a standard HRT protocol. I don't really give it. There are people who like to give it. They may continue to give it. I don't use progesterone capsules. I don't use progesterone injections. Okay. And I don't really use so much of supplementation apart from this. All of you have normally seen my papers. At least some of you have seen my papers because of cross patients. And you know, I am doing the exact same thing. Okay. There is no miri masala. I don't like to give Vizolone to all patients. In fact, I hardly give it. Okay. I don't like to give Vizolone. I don't like to give sildenafil. I don't like to give arginitric sachet. None of this is given. Okay. So usually these are very happy patients, the ones who are undergoing an embryo transfer with us. Okay. This HRT forms approximately 75% of the patients. See what is there. First day you call for ultrasound, 9th day you call for ultrasound, and then there is directly embryo transfer on 15th day. So the patient has very limited visits. Okay, the patient has really limited visits to the hospital. The patient is super happy. Okay, this patient is super happy, right? Now, for approximately 25% of the patients whom we treat in our hospital, all right, we are going to follow modified natural cycle protocol. We do not follow the true natural cycle protocol. So when we are following a modified natural cycle protocol for FET, what do we normally do? When the patient comes to you on day 1, 2, or 3, okay, from the 3rd day onwards for 4, 5, 6, 7. So day 3, day 4, day 5, day 6, and day 7, we give the patient letrozole. Okay, now I know there are certain people who are very, very fussy about not calling this to be modified natural cycle protocol. They want to call it to be stimulated modified natural cycle protocol. Okay, so this is written only to keep them happy, but nothing really changes as far as the ovary or endometrium is concerned. Be happy that some extra word was put to add to more confusion. Okay, so what typically happens is after 5 days of letrozole, day 8, day 9, 10, day 11 or day 12 is when the patient comes for an ultrasound. Okay, so this is your primary ultrasound. After that, you have given letrozole 2.5. After that, the patient comes for an ultrasound. Now, usually this is going to be a quiet ovary. Here, when the patient comes, the lead follicle of the ovary, which you see, this dominant follicle has already become approximately 18 to 20 millimeters. All right. It could be a single follicle in most of the situations. We always do an estradiol, progesterone, and LH here. This is important for people to understand. Usually now people will say, "Arey, now your estradiol will not be more than 200." Agreed. Estradiol any value more than 50. Progesterone any value less than 1.2. LH any value less than 15. Okay. In this situation, for this, we will give 10,000 HCG trigger. Okay, and now remember this simple rule. After you give 10,000 HCG trigger, okay, blastocyst, that means embryo transfer for day 5 should occur on the 7th day post trigger. Very, very simple. Okay, I'll put it in Hindi. अगर आपने trigger दिया है Monday को, next embryo transfer should be on Monday. If you give trigger on Tuesday, embryo transfer on Tuesday. Don't use your head. Monday, Tuesday. Very, very simple. Commonest question people ask, and they ask after every masterclass, is when to start luteal phase support in this. So the luteal phase support which we give only is progesterone gel. In this, you don't really have to give anything else. I like to give gel twice in a day. If the trigger is given to the patient on Monday, gel starts on Wednesday morning. If it is given on Tuesday, gel starts on Thursday morning. Ek din chhod ke. If you give it on Wednesday, you start it on Friday morning. Very, very simple. Okay. I hope you understand this. It is so simple. You don't really have to do anything additional. The advantage here is that you don't really have to give even estrogen, because that much amount of estrogen is going to be secreted by a good corpus luteum here. It's a monofollicle development. It secretes something very, very nice. Okay, so this is the modified natural cycle which I follow. Now, the only problem which occurs in this is sometimes you are going to be in this confusion with the LH. Sometimes LH will be 17. Ab kya karega? Now what you will do? Hai na? So now you will be in confusion. Arey, LH is 17. Now what I do? LH has already surged. Now what I will do? Okay. So in this situation comes your skills of doing an ultrasound. See, when this LH is about to surge, remember we have taught this to all of you in the classes so many times, but obviously it is difficult to remember because we are taking an abundance of master classes. So unless somebody has ingrained this in their head, it could be slightly difficult to remember. Okay, but I'll just explain it and show it to you again. All right. When you do when the LH is, let's say, more than 17, that means we think that there is an it is in LH surge. Okay. Though there are no great definitive criteria, this is one of the criteria. All right. So what typically happens now, guys? Before this LH surge occurs, the estradiol would surge and then estradiol would shallow out. Okay. So I'll draw LH surge in green color, LH surge, green color ka. Now, before this LH has surged, God does a small progesterone spike. Okay. This small progesterone spike starts to induce some secretory changes in the endometrium. What is this secretory changes? This triple line is otherwise going to appear exactly like this. Now, this small secretory changes matlab thoda sa haziness. Okay. One of the earliest signs is appearance of haziness and slight dissolution of this basement membrane. Now, if you are very good, you will pick this thing up and then you will not cancel this particular cycle. What you will do, if LH is more than 17, there is no need to give any trigger figure. God has naturally given trigger in that situation only. Okay, only and only in that situation when LH is more than 15, jo maine describe kiya. Okay, so when you wonder that there is an LH surge, only in situations when LH is more than 15, that is our criteria which we follow. Okay, and if LH is more than 15 on Monday, okay, your embryo transfer will be on Sunday. Simple. 6th day. Okay, easy rule. If you think it is on Tuesday, kabhi jayega ye? Monday ko. Remember when there was no LH surge, okay, I will write it down so that people can understand. When there was no LH surge and you gave trigger, in that situation, if you gave the trigger on Monday, embryo transfer is on next Monday, 7th day. But if there is an LH surge, it is on the 6th day. Bus. This is the only practical difference which you have to remember. Yes, of course, there is one more small difference. Here we are told if it is Monday, luteal phase support will start on Wednesday. Here, if it is on Monday, luteal phase support will start on Tuesday. If it is on Tuesday, it will start on Wednesday. Bus. This is the only difference. Okay. Obviously, if you go through this session 3-4 times, you will understand this entire thing in your head absolutely by heart, because that is how it is, at least in my head, because we have been doing it for a very long period of time. And I think it is very good to do a modified natural cycle rather than doing a true natural cycle, because in a true natural cycle, you really have to call the patient again and again and again and identify rupture, no rupture, rupture, no rupture. And sometimes the patient will get mad. Okay. And especially when you are doing around 120 embryo transfers in a month, and if you are doing true natural cycle for everyone, remember your modified natural cycle and true natural cycle will work the best, especially in patients who have a normal AMH. Because for the endometrium to be secreted nicely, you need a very good oocyte inside. Okay. And you are dependent on that good oocyte. Okay. So you need to have patients for normal AMH. If you have low AMH patients, then we switch to HRT protocol. We don't create a fuss about doing modified natural cycle. All right. One more last thing I would like to add. I never ever give antagonist in any of these cycles. Okay. I have told you that we may give half dose antagonist when the patient is trying naturally in IUI cycles and all these things, but no antagonist to be given in any FET cycles, because it's very simple. Endometrium has GnRH receptors. If you give an antagonist, it will cause a falsely low estradiol onto that endometrium, which can cause the endometrium to break. And this endometrium, when it breaks, it will reduce the implantations. Okay. So I hope this session helps, and I'll be happy to answer 4 or 5 questions now.
So do you use LH for the natural cycle?
Sorry, madam.
So do you use urinary LH kits?
See, there is a problem in using urinary LH kits. Actually, people don't understand this. For LH to get cleared in the urine, no, madam, it will take that little extra time. So, for example, after the LH surge has occurred, let's say LH surge occurred on Monday, by Tuesday, from the serum, LH level will fall down very drastically. Okay. But for it to fall from the urine, it will take up till Wednesday. So what will happen is when you use urinary LH kits, you will have this false positive LH surges, which you keep on seeing. And that will skew your window of implantation. So better is to use serum LH, in my opinion. I am not at all a fan of using urinary LH kits.
Okay, so in HRT cycles, you said you start the E2 either on day 1, day 2, or day 3. Which is the preferred day that you start? And what is the latest?
Day 2 or day 3 is good. Try to not start it on day 4, because by that time, you may have an abnormal follicle which has started to develop, which may keep on growing despite the presence of external estradiol. Okay. And which will again skew your window of implantation. Second thing, madam, in modified natural cycles, we never add HMG, because once you add HMG in that particular cycle, your luteal phase is compromised. So we never do that. Just letrozole alone is enough.
Okay, so you showed that you use the incremental E2 supplementation.
One can use a standard dose. It is equally good, to be very honest. This is a protocol of using incremental we have been following since 6 years. We really don't want to change it, but I just described the protocol which we have. But even if somebody is using, let's say 6 mg of estradiol hemihydrate or even estradiol valerate for 9 days, it doesn't really matter.
Okay, so, but you use hemihydrate, or you have changed it over since how long?
See, we were using estradiol valerate for approximately 6.5 years, madam. We have switched from valerate to hemihydrate since the last 4.5 months only.
Okay, okay. So have you noticed that the E2 values are more with the hemihydrate than with valerate?
No, there is no such thing. I know there are studies which are telling all these things. The day we have a class on only estradiol, okay, we'll probably teach everyone that measuring estradiol values is a big headache. Okay, but we'll enter the details at that time.
So if the patient is intolerant to oral estradiol, so what do? Do you use?
There is an estro gel which is available, which is also very good for patients who are intolerant. Otherwise, you use true natural cycle for those patients. No.
And do you routinely do in HRT cycles E2, LH, and progesterone levels before starting the progesterone?
LH is only in modified natural cycles, madam, as I mentioned.
You don't use LH levels before starting the progesterone in HRT cycles to check if there is escalation?
No.
No?
Ultrasound is more than enough. I will give you a typical example, madam. See, sometimes you have these patients where you have given them estradiol, okay, and what happens is the lining becomes secretory just on estradiol. No, we see that very commonly in HRT cycles. Progesterone value will be 4.5 suddenly. Okay, the reason for that is that these are the patients who have this slightly abnormal estradiol receptors in the endometrium. So these are the patients who will do the best when you give them an estradiol gel or when you switch them to a modified natural cycle protocol. And remember, even if the lining appears to be slightly more secretory in these patients, if progesterone is less than 1.2, their window of implantation will be intact. Okay, if you have used an HRT protocol. So a lot of times I've seen people cancelling cycles using GnRH agonist to reduce progesterone levels. It's not going to work. Okay, the lining appearance may be different, progesterone value may be different.
Okay. And maximum dose of estradiol that you use, you showed the standard is 6 mg. But
we don't exceed 8. I know there are people who are happy using 10 and 12 also, but we don't exceed 8.
Okay. And what is your cycle cancellation rate with HRT cycles?
2%.
Okay.
It has never gone up beyond 2% in the last 10,000 HRTs. Okay. It has never gone beyond that.
And below what thickness of endometrium you don't transfer, and above what thickness?
There is nothing like that. If there is a triple line for a patient which is coming at 6.5, okay, sometimes it is going to happen. For that particular lady, the uterus, I mean, the best endometrium thickness is 6.5, and see, there is not a great difference between 6.5 and 7. It is 0.5 millimeter. So it is how much you magnify the endometrium and how you measure it. Do you actually measure it from outer line to the outer line? Then 6.5 will become 7. So we don't really follow that criteria, but the nursing chart says it has to be more than 7 mm. So when the patient comes and let's say it is 5.9, then the automatic instruction is to continue estradiol hemihydrate for 3 more days. Okay. And the patient comes back instead of the 10th day on the 13th day. Simple.
Yeah. So do you ever use progesterone intravascularly? You said you use mostly gel. but have you used any other mode of administration of progesterone?
We hardly use, madam, anything else. We very hardly use. I mean, very rarely for patients who are more than 40, we may like to give 1 or 2 injections of progesterone, oil-based preparations, okay, just to ensure that the serum progesterone level stays good for them. But apart from that, we really don't change it.
Okay, so you said maximum number of days of estrogen that you have used is 28 days.
So max allowed, I think, is 28 days. I normally don't try to exceed around 18 to 20 days.
Okay, so then you cancel and then you restart again with modified.
Cancel and restart. Yeah, because see what happens is, no, irrespective of what people say, prolonged exposure of estrogen to the endometrium causes atrophy and it reduces the success rates, madam.
Okay, and do you continue this estrogen and progesterone after the beta HCG is positive?
Till 8 weeks.
Okay. And adjuvants, you said you don't use any. So do you use GCSF in case of thin endometrium?
No, it doesn't work.
And have you used intrauterine HCG instillation?
Never.
What about endometrial scratching?
Doesn't work.
And PRP?
Outdated.
So in your practice, HRT cycles is 75% and modified natural cycle is 25%. So, so you, based on the AMH, you classify them and make a note on the case paper saying that they will go for
Patients who have undergone double stimulation will always be on HRT cycles. Patients who have undergone non-double stimulation, that is when we decide if to use HRT or modified natural cycles. Patients with PCOS will always be on HRT cycles.
And so in your practice, what is the percentage of frozen transfers and percentage of fresh transfers?
99% is FET.
Okay. So do you do single embryo transfer or do you do double embryo transfer?
It depends on what the patient signs up for. If they've signed up for SET, then SET. If DET, then DET.
Okay. And how do you manage breakthrough bleeding in case if there is any during the stimulation with HRT?
That is going to be predominantly dependent on the quality of drug which you have chosen for estradiol, valerate or hemihydrate, not on patient consuming it correctly or not.
And in cases of adenomyosis and endometriosis cases, do you do the HRT cycle?
We don't do that, madam. As you know, in cases of adenomyosis, if the uterine size is less than 10 centimeters, we give them 3 months of letrozole plus regestrone. It causes volumetric reduction, and then we start the HRT protocol.
So instead of letrozole, have you used CC for modified natural cycle?
No.
And in modified natural cycle, do you supplement them with estrogen during the?
No. In modified natural cycle at LPS, it's only progesterone gel, as I mentioned.
Okay. And here, take some of the questions.
I saw one question that don't you use PRP for thin endometrium with a big question mark? Are not just I, nobody in Europe is also using it. I know, you know, for people who actually went to ESHRE and by mistake attended it, they will come to know that PRP is considered to be outdated. Okay, so you can do it to show something to the patient what magic has been tried, but PRP doesn't really work. Okay, and I'll give logic to it, so don't worry. When I take a class on PRP, it will be worst for the PRP tube manufacturer.
Okay, I'll apply leave on that day.
Yeah.
So if follicles don't develop, especially in low ovarian reserve in modified natural cycle, so anyway, you say low ovarian reserve, usually it will be dual stem and you go for HRT cycles.
HRT
right?
only. Yeah.
So endometrial waves, do you look for it?
No, I never look for it. See, all these endometrial waves and all, no? If you look for it, no, you will be able to do ultrasound of 2 patients in one day. Okay? If you have around 70-80 follicle scans in a day, no, You will have to have 70 scan machines. People looking at wave, wave came. Then 2 people will fight over it. It was half wave, full wave, all that rubbish. Okay. So we don't use. One more important question has come. Do you use atosiban? I don't use, because at that point in time, there is no oxytocin receptor only. Okay. If you attend an obstetric conference by mistake, you know what will happen is they will spend orations discussing that, oh, atosiban has sponsored us, but don't use it before 25 weeks because there is no oxytocin receptor. So how do you expect a 6-week uterus? What 6 week? How do you expect a uterus to develop an oxytocin receptor? I mean, I don't know. But maybe what I have heard from people is that because there is some VEGF receptor uptake, downtake, which happens with this atosiban. But normally what I understand is that will happen when you give a loading dose. That means full dose, 48 hours. So you have to keep the patient admitted for 2 days before embryo transfer. Okay, to probably get some effect. So I don't know. I have not tried, okay?
Okay.
I am not the right person to comment.
Okay, yeah. I think we are done. The rest of it we'll take in the groups. Thank you so much. It was an excellent session. Very, very, very nice and crisp. Thank you.
Yeah, thank you so much.